First of all, thank you, SRS organization, and also the SICO organization for inviting me here to Prague to give this talk on a very interesting subject indeed, the evidence for pedicle screw systems that everybody's using today. What is actually the evidence? Preparing for this lecture, I read this interesting comment by Professor Zook. He was the guy behind the segmental screw fixation, as we all know. And this was in the Clinical Orthopedics last year. And actually, if you read this, this is one of the first sentences in his paper. Non-segmental pedicle screw fixation can be effectively used in mild and flexible curves. Non-segmental. This is from Professor Zook. And the second, more or less, paragraph is, in severe rigid scoliosis, bilateral segmental insertion can be applied to increase the rigidity of the fixation, especially in the lumbar levels. A very kind of surprisingly weak statement from the guy behind segmental fixation, traveling the world for 10 years, telling everybody to put 2 screws in each vertebra in idiopathic scoliosis. So, looking a little bit at the evidence, there is some substantial evidence that all screw constructs do correct the coronal plane better than the hook constructs. Like a Kim paper, it's a Lenke group paper, 76% improvement with screws compared to 50% with hooks. Also good papers from the US with the Crawford group, compared hooks and wires with screws only and screws, hooks and wires, and they controlled for differences in flexibility between the curves. And in fact, they had the best correction with the hooks and wires, excuse me. But the differences were not significant. So they came up with pretty much the same coronal plane correction, in fact, with the different systems. They commented on, which is very often commented on these days, and also like Dietrich commented on, that screws gave a more lordosis of the thoracic spine, and concluded that there was no advantage with all the screw constructs. What about vertebral rotation? Because vertebral rotation is really the argument for using the segmental pedicle screws. And actually there are very few papers looking into this carefully. And this is the only computers tomography-based paper I could find. It's by the Harm Study Group, when they looked into the apical vertebral rotation, and they compared it to the very historical paper by Ecker from 1988, in which he found a 22% vertebral derotation, and they found vertebral derotation by 60%, indicating an improvement, even if the comparison may be a little bit one could question. The technique of direct vertebral derotation, as we all know, varies a lot between surgeons and centers, and I don't think there is a agreed technique, optimal technique for doing this. I think everybody's using a little bit differently. However, what is the important thing is not the rotation of the vertebra. As we all know, the important thing in idiopathic scoliosis is the rib hump. Surprisingly, very little work is done on the rib hump, although segmental pedicle screw fixation has been now used for 10 years or something like that. The reason for this, I'm not sure. Just a historical looking back at the CD constructs, which we did already at that time. CT analysis of the rib hump, which is the most precise method for doing this. In fact, which found with CT hook constructs a 41% reduction of the rib hump, and 20% of this maintained at 2 years. Then we did this in the USA with Transfert Group in Twin City Scoliosis Center. They also using the CT technique. In fact, we've had exactly the same results in Minneapolis with the CD constructs. This is not so much appreciated, but in fact, as we all know, the ones of you who did CD in those days, that you did get a rib hump reduction. It was not perfect, but you did get it. And I think this reflects something like what we actually accomplished 20 years ago, with 20% reduction of it, something like that. And how about today? Using pedicle screws. Suk have published on this with using pedicle screw constructs only, and he found a 38% improvement. Men did find the same, 37%. And Suk, when he added the thoracoplasty, had a 58% reduction of the rib hump. And this is not CT analysis, this is scoliometers and stuff like that, using radiographs, rib hump quantification. And with direct vertebral rotation, Suk actually, if you look into his papers, and all his cases he's doing with thoracoplasty, and this is not always appreciated. It's not the direct vertebral derotation only, but all his results is combined thoracoplasty and DVR, and his published figures is 72%. But you can't really tell from if this is only from the DVR or not. In fact, in literature, as far as I know, looking into this stuff 3 weeks ago, there is only one study on DVR on the rib hump without thoracoplasty, which is kind of surprising. And this is the paper by the also an American paper with Peter Newton, and the first author is Wang, and I think it's a combined paper also from Canada, San Diego, etc. It's not a CT analysis, it's a scoliometer paper. They looked into 148 patients, multi-center retrospective study, various derotational techniques used, and they found a 54% improvement of the angle of trunk rotation on the scoliometer. In fact, from 14.8 degrees to 7.5. This is the patients they published in their paper. I'm not sure it's the best patients, but in these patients they have a 70% correction of the angle of trunk rotation. And the crucial question is, does a 50% or 54%, as in this paper, reduction of rib hump justify segmental pedicle screw instrumentations and direct vertebral derotation in adolescent idiopathic scoliosis? Already commented on by previous people is, as we all know, it flattens the spine. It seems to flatten the spine. This has been shown in a couple of papers now. It seems to be a very predictive thing. Maldenkoff paper this year, thoracic kyphosis and lumbar lordosis decreased by 8 and 11% respectively, whereas when he used simple rod rotation, he had an unchanged sagittal profile. So what about patient-based outcomes? Also, surprisingly, having the SRS questionnaire around for so many years, very few patient-based outcomes reported. At least in literature, there may be abstracts and so on, but very little presented on the effect of vertebral derotation. Does it affect the patient at all? We did this study, 157 idiopathics, operated. This is a retrospective study. Strategic pedicle screw instrumentation, 54, segmental, 46, hybrid, 57. Can I have the slide, please? And this is what I mean with hybrid. It's like the Mark Asher type of thing with wires, apical region, screw below, hooks above. Strategic is what I mean is a little bit like this, occasional screws, a little bit like every second vertebra on the concavity and every third on the convexity, and a little bit more screws in the lumbar spine. Segmental is more or less screws in every vertebra, like seen on the right. And in the segmental, direct vertebral derotation tried. And the hybrid, of course, no derotation. And these are the comparison between the pre-op and post-op. The correction was pretty much the same, 35 degrees with the coronal plane, strategic, 33 segmental, hybrid 35. This is the SRS 22R total score. And you can see the strategic 4.22, segmental 3.80, hybrid 3.96. No, not significant difference. If you go into function, the same thing, strategic best, and the same pattern with segmental worst, but not significant. If you go into pain, same pattern, non-significant. If you go into self-image, the very variable that segmental pedicle screw fixation is supposed to affect, segmental PSI worst, again, not significant. Mental health, same pattern. Treatment satisfaction. In fact, the hybrid best, but similar outcome rates with no significance. So if you summarize the quality of life in these patients, a slightly worse outcome for the segmental instrumentation for all scores, in fact, however, statistically not significant. The only significant difference between the groups were cost. The cost for the strategic was 7,000 euros, for the hybrid 6,000 euros, and for the segmental 10,000 euros. So if we summarize that study, similar coronal correction rate, similar clinically non-significant loss of correction, disease-specific quality of life similar for all techniques, segmental PSI more expensive than the other ones. Few comments on the pedicle size, because that is of course of importance. We're talking about instrumentation with screws. My good friend Aki Olin from Malmö in southern Sweden did this work with Kasim Abul Kasim, who is a radiologist, and they've done low dosage CT for a number of years in idiopathic scoliosis. And this series is 61 consecutive scoliosis patients, and the mean pedicle width on the right T4 level was 2.6 millimeters. The mean left T7 pedicle width was 3.2 millimeters. In Lancet type 1 curves, 97 of the patients had at least one pedicle less than 4 millimeters. So in fact, all adolescent idiopathic scoliosis have pedicles smaller than the usually used pedicle size screws on the market. So a little bit, we can conclude again a little bit what I find from the literature and from my own experience is similar coronal correction, flattening problem with the screws, derotation of the vertebra better with the pedicle screws. The rib hump improvement is better. Only one study, however, and it's done with a scoliometer with precision is not that great. Patient outcome better, not reported as of yet, having this technique around for a decade, which is very surprising. Many surgeons have recommended this, not the least SRS President Larry Lanka and Suk, of course. To have the patient improved in their outcome, very crucial question that we need to have an answer to, I think, soon, because we're subjecting these patients to tons of metal with no really good argument for it scientifically. So is it worthwhile? The pros is it's the only potentially useful implant for derotation. If we now forget for a while the anterior one, we forget that for a while if we're talking posterior surgery. What about techniques? They're constantly evolving. The data I showed was from 2008 when the techniques we were using were maybe immature. Everybody's working on this now. Maybe we're doing better now. Also, I think a pro is that in severe curves, it seems like segmental pedicle screw fixation does improve correction. The con list is longer, the cost is higher, the risk is higher by pure mathematics. The more screws you put in, the more danger you put to the spinal cord. 17% of the screws are misplaced. This has been shown in a number of studies, and particularly in the Swedish study doing CT scans. 97% of patients have at least one pedicle less than 4 millimeters, operative time longer. What about stress shielding, as Dr. Slenska commented on? What happens 65, 70 years with this kind of spine? Maybe nothing, maybe severe stress shielding with osteopenic vertebra up in front. We just don't know. What about the metal ion load? Maybe not important. It cannot maybe totally be excluded that you expose the patients from this amount of metal. Is that healthy? I'm not sure. Why does parents want to have metal removed from the kids? Maybe it's an emotional thing. We just don't know for sure. So we need to demonstrate that actually the patient outcome is improved with doing this kind of surgery for what used to be very simple surgery. Very quick, simple 2-hour surgery is now 4-hour surgery with tons of metal in the patients. This is how I do it today. This is a 15-year-old adolescent idiopathic scoliosis girl operated on last Monday. She was sent back to her home this Sunday. Blanket type 1 curve, 65 degrees, somewhat hyperkyphotic in the thoracic spine, somewhat hyperlordotic. We also do now CT scans, low-dose CT scans, 0.37 millisieverts per patient. I can really recommend this kind of analysis on your patients. Very low dose. And it gives you a very good idea how the pedicle looks before surgery. And confirming the Malmö data, the outer diameter of this T4 right pedicle is 3.1 millimeters. So that's why I put the you can see on the top to the right hook claw construct. Did use pedicle screws on the apical region. Did try to derotate the spine, and maybe accomplished a little bit. But as you can see, it's not totally derotated. There's some derotation left from the angle of the screws. This is what I did 5 years ago. This is 16 years old girl with adolescent idiopathic scoliosis, Lanket type 1. One, I think it would be a B. Very simple surgery, like under 2-hour surgery. Maybe not perfect coronal correction, maybe not perfect derotation, but quite still good derotation. This is the gal, 18 months after surgery, biting her bronze medal from having the bronze medal in National Junior Championship in breakdance. Showing that at least from a functional point of view, the way we did surgery a couple of years ago was, very acceptable. So I don't think we improved functional with tons of screws in. Maybe we improved cosmesis, but it remains to be documented. Thank you.
Thank you, Rune. The last talk